My name is Mark Sherwood, and I am honored on behalf of myself and my co-chair, Ali Hafez, to introduce the session for the International Society of Glaucoma Surgery on rescue operations in glaucoma surgery. We have an excellent international panel of speakers. Our first talk will be Managing Failure in Trabeculectomy and will be given by Professor Michael Coote from Melbourne, Australia. Our second talk will be on common tube problems and remedies and will be given by Keith Barton from London, England. Our third talk will be what can go wrong in MIGS and how to manage, and will be given by our society president, Tarek Sharawi. Our next talk will be prevention and treatment of complications of micropulse laser and will be given by Professor Paul Chu from Singapore. Our fifth talk will be complex problems in trabeculectomy and will be given by Professor Tanuj Dada from New Delhi, India. Our final talk will be given by Professor William Sponsel. He will be talking on glaucoma surgery for the underprivileged, and he is from Texas in the United States. Thank you.
Hello, my name is Michael Coote and I'm from Australia. And I'm so sorry that we can't meet in person. It's very interesting and difficult times for all of us. So I'm talking about rescuing of blebs and the restoration of glaucoma surgery. And we all will need some skills in this area if we're going to be glaucoma surgeons. I have some disclosures, although none that are relevant to this talk. Most blebs, in fact, will need some form of revision over the whole of their life. In fact, within the first 5 years, around a third of them will need some work. Some will leak, some will overdrain, some will spread too far, some will become uncomfortable and dangerous. But most commonly, what will happen is that they fail to function. And of course, aqueous has to go somewhere. There are three basic parts to functioning glaucoma surgery. Aqueous must leave the eye through some form of ostium, protected or otherwise. It must distribute in the subconjunctival space, and it must then be absorbed into the vasculature of that space. So failure of a glaucoma operation can occur in many places. It can occur from inadequate outflow, or from inadequate dispersion, which is the distribution, or from inadequate absorption. Now, just a moment to understand what inadequate means. It means that the total outflow of the eye, that is the existing plus the surgically induced stuff, the stuff you did, does not manage to produce target intraocular pressure. So it's not a fixed definition, it's a very flexible, it's a very person-centered specific diagnosis or problem. Now, if we're going to fix blebs, what we need to do is do some kind of ante-mortem, post-mortem on them. We need to diagnose what's happened. And there are basically three parts where failure can occur. The first is the internal ostium. The second is the flap, and they're slightly different from each other. And then the third is the bleb complex, somewhere in that space. Now, a word about blebs again. Blebs accept the volume of aqueous that is needed to create target pressure. Some of this is a little less obvious than it seems, but essentially what's happening is intraocular pressure eventually is determined by the porosity of the bleb wall. So that the aqueous has to flow through the bleb wall and it has to remain manageable. In other words, the stress on the bleb wall is not sufficient to cause the bleb wall to decrease or increase in porosity. It has to stay relatively stable if indeed we're at target pressure. And blebs absolutely need to work. So if you have this diagram, this is a kind of version of some stuff we did with some structural engineers, computational engineers, who looked at what was the proportion of outflow related to the bleb or native at different pressures. And you can see that blebs often fail partially. So if you have a pressure of 24, the bleb might in fact still be working if the underlying pressure is 30. But there are many moving parts in all of this. The key to the whole process is tissue porosity, and that's not something that we can actually measure directly. We measure it indirectly. Just to remind you, tissue porosity is determined by the structure, is determined by the extracellular matrix, not by the cells, although the cells produce the extracellular matrix. The bleb failure is therefore in the subconjunctival space, and what we look for is some features of the bleb that tell us something about how it's working. There is low lateral resistance and high lateral resistance, but all blebs function in essentially the same way. Now I'm going to show you a video of a revision of a bleb using a posterior technique. Posterior techniques are certainly simpler than anterior techniques, as broadly you're entering the bleb from an area of relatively normal tissue. Having said that, after a trabeculectomy in many years, none of it is particularly normal. You'll see this episcleral tissue that's getting peeled away. This stuff is really important to remove. Apart from anything else, you're going to need to have some kind of clear definition of sclera underneath. Remembering that these days what we do is make blebs through chemotherapy, so what we're doing is trying to create a space for the chemotherapy to work. We need this ostium, so we're moving now over the top of the flap just to get us a little bit of space. Now we'll delineate just one corner. We don't need to open the whole thing. If we open the whole thing, we'll just have prolonged hypotony. Now this has been a flap failure, and what we can do is get underneath it. Now we're into the anterior chamber. We can see fluid coming out. You'll notice that it's quite easy to go too deep or too shallow. We'll usually then fill the anterior chamber up with viscoelastic in order to create some positive pressure. So you'll notice that the anti-metabolite, mitomycin in this case, is being used at the end of the procedure. Sometimes you just need to make sure that the trapdoor can stay fairly open. And then what we're going to do is create a space for aqueous to distribute. And we need to move some of this tissue around just to make sure that there's sufficient space. What we don't want to do is have pre-existing bands of tissue in order to help block this up. Opening up that sclerostomy with a little bit of diathermy is a good idea. This is mitomycin, 0.4 or 0.5. It's not a polyvinyl chloride sponge, so it's something that's quite good for this sort of process. Has a sort of stock amount of mitomycin in it. You have to sort of push it in a little bit, as you can see. I like larger pieces just so that we're controlling the amount of mitomycin. Remember, this is topical chemotherapy, so there are all sorts of problems associated with it. And if there's a lot of blood, you're going to absorb it. This is just a reapplication, just close flap failure. If it's occurred once, we certainly don't want it to happen again. All right, then we close it with Vicryl and we put in some dexamethasone. So just to remind you, biology is not here to help us. Trabecular meshwork is the only passively porous structure in the body. Fluid management in mammals is incredibly important. Don't blame the patient, but there are always fixes for failures. Go ahead and do good. Thanks for your attention. Goodbye.
Ladies and gentlemen, I'd like to thank the organisers for asking me to speak about common tube problems and remedies in 7 minutes. I work with a number of companies and these are my financial disclosures. Shunt complications include low pressure, high pressure, corneal endothelial cell damage, exposure and diplopia. Low pressure is quite a common early problem and maybe a late problem. It may be due to an overdraining tube or peritubular drainage around the tube. There are a few options. You can ligate the tube and close it off, or you can stent it. Ligation is not titratable. There's a high risk of quite a binary outcome, either pressure too high or pressure too low. Stenting, on the other hand, is less dramatic, often elevates the pressure significantly, but not a lot. This is an overdraining Barvelt, which I stented with a 10mm length of Supermid from the anterior chamber. And this is my go-to technique if a tube is overdraining and it is not already occluded with something. The pole glaucoma implant is a smaller tube and can be stented with a 6-0-proline, which is a little bit trickier to get in. Here I'm using 23 gauge vitrectomy forceps Peritubular drainage occurs if the entry site is larger than the tube diameter, or there's thin sclera around the entry site, or scleral necrosis from tube movement. For peritubular leakage, I use a little spear or arrowhead of pericardium or fascia lata or donor sclera, and literally physically push it into the hole to bung the hole like a cork. You can see this little one was a little bit loose, so I've taken a larger one, and I speeded this video up for the sake of time, but you can see how you need to push it in quite forcefully to actually get a watertight seal, which I've now achieved. It's then sealed using tissue glue, and a patch of pericardium is put over the top in the normal fashion. So that was low pressure. Now high pressure is obviously common as well, and it may be due to simple failure of pressure control due to encapsulation, but sometimes it's due to iris obstructing the tube or even vitreous obstructing the tube. So it's first important to check tube patency. If you cannot see the tube visible directly at the slit lamp, make sure you look on gonioscopy. If not visible on gonioscopy, is it retracted? Is it obstructed? Is it in the sulcus or vitreous cavity? This one wasn't visible on direct slit lamp examination, but it's clearly patent on gonioscopy. The Byzanti was quite useful for identifying tubes that have retracted, such as this sulcus one, which is retracted into sclera, or this iris obstructed tube in a patient with a hazy cornea where it wasn't clear whether the tube was obstructed or not. What about a tube in the sulcus or in the vitreous cavity? These may be harder to visualize, and it is possible for a vitreous cavity tube to block with vitreous even with a previous vitrectomy, as in this case where vitreous base was caught on the way in. This was an aphakic patient where vitreous got stuck up the tube. Either way, if vitreous is stuck up the tube, you need to remove it. So if a tube's obstructed with iris, you do an iridectomy around the tube and take the iris out of the tube. If it's obstructed with vitreous, you perform a vitrectomy. However, it is always worth considering if reobstruction is likely to occur and whether the tube needs to be repositioned. I must re-emphasize that YAG laser rarely works in these situations. If iris is engulfing the tube, as in this case, it's simple to remove using 23 gauge vitrectomy forceps and scissors. You can literally do a simple iridectomy around the tube. It's a shame because this patient already had a large iridectomy and the tube really should have been placed in that in the first place. The tube is gently teased to clear the iridectomy using viscoelastic. Note there's still a supramid suture inside, so you do need to remove the viscoelastic or you'll get a very high pressure afterwards. If you do need to move the tube and you need more length, simply move it more radially if it's a tangential or oblique approach, and more posteriorly into the sulcus, as both of these techniques will give more length. If repositioning is required later, an oblique tube can be repositioned more radially, adding length in the anterior chamber. This tube's in the sulcus, so will automatically be longer than the same tube if it's in the anterior chamber. If you do need to use an armored extender, be very careful because these large plastic plates can easily erode if they're very close to the limbus as positioned here. They need to be placed much more posteriorly and patched. This bar vault is short in the anterior chamber and has become obstructed by a membrane of surrounding endothelium, which is relatively unusual. You can see Schwalbe's line here, you can see the angle. So this tube is blocked with endothelium because it's actually in the cornea, so it's also a danger to the endothelium. Repositioning the tube in the angle will give extra length, unblock it, lower the IOP and protect the cornea. So that was not only high pressure but also introduces us to corneal endothelial damage, which is a significant problem if tubes are not carefully placed. This is a prospective study of tube position in the cornea and the effect on endothelium after 5 years. And if a tube entry site is behind Schwalbe's line in the angle, at 5 years you still have almost 25% loss of endothelial cells. But in the long term, there's very low risk of corneal decompensation. If the tube is straddling Schwalbe's line at the entry site, there's a very high endothelial cell loss rate, double in fact at 50%, and the higher risk of corneal decompensation in the long term. Long tubes can move and damage the endothelium, but it's actually tubes that are close to cornea and tubes that have an anterior entry site that cause the greatest risk for corneal endothelial cell failure. So that was a brief summary of the effect of tubes on the cornea. Exposure is always a small ongoing risk, and it's a huge area to cover, and I will not be able to do it justice here. So ladies and gentlemen, I've given you a 7-minute appetizer on common tube problems and remedies, but thank you very much for your attention.
Good morning, friends and colleagues. It's a pleasure to be with you in the ISGS Symposium for the World Glaucoma Congress. I'm wishing you a great Congress. I'm speaking from Geneva. I've been asked to speak about the troubles with the new types of glaucoma surgeries, MIGS. Not so new now. We have been doing those for more than a decade. And when they first were introduced, they were supposed to shine in and show us the light at the end of the tunnel. Well, with the advances in glaucoma surgery, there have been, as you can see, multiple different ways to approach glaucoma surgery in a minimally invasive manner. So whether we are relying on subconjunctival filtration, enhancing the Schlemm's canal or the traditional outflow pathway, going into the suprachoroidal space, or even destroying the ciliary body in a more focused way, all those new types of glaucoma surgeries were supposed to make our life easy. And in many cases, they have done that. They have succeeded in making our life easy. But as is the way in life, anything new comes with its own set of advantages, but also of disadvantages. So first, we were supposed to gain something major from MIGS, which is to actually develop blebless surgery, surgeries for glaucoma that do not depend on subconjunctival bleb formation. And CyPass was something that was FDA approved and CE marked and was used widely all over the world, I would say. But then soon we learned that it comes with a price, and the price is not only in the amount of dollars that you're paying, but also in the sense of endothelial cells that we are losing with putting a device into the antechamber close to the cornea and putting it permanently. Unfortunately, this is true for CyPass, but anything that you put in the antechamber permanently, especially if you're close to the cornea, as in valves and any types of stents, there is a certain degree of the endothelial cells that will happen. Second came the idea of a hybrid bleb. I have observed those blebs since the start, and they are interesting. All the new subconjunctival filtration devices, whether micro shunt, pressure flow, or something like the Zen implant, as you can see, their outlet for aqueous is a lot further from limbal filtration, as we see with trabeculectomy or with deep sclerectomy. It's not as far as you would see with an AMID or a Barvel tube, but still it is far enough to develop these kinds of blebs. You can see here a bleb that is relatively shallow. It is not too prominent. It's far from the limbus and it's functioning. And those blebs are usually very comfortable to our patients and are one of the main advantages of those new subconjunctival MIGS. Having said so, as with any subconjunctival filtration, as you can see, those can scar. So you can see here that this is one of those implants, and the conjunctiva has fallen completely around it. It is almost jumping at you. There's no filtration whatsoever. Now, those cases can be managed through needling, though I will strongly warn against needling of those devices, because in many cases you would hit a bleeding will happen, and you will not see what you are actually doing. And in some other cases, there is dense fibrosis around those implants, and you might end in amputating or circumcising those devices. So I'm not really very big on needling. What I usually do is actually open, clear the fibrosis, put mitomycin, make sure that the implant is in the right place, make sure that filtration is happening, and then closing. And my results with revising those implants has been quite satisfactory. All the implants that I have revised, I was able to bestow upon those implants a second life that would go on sometimes for many years. But one other complication that can happen is an erosion of the implant. As you can see here, this is a Zen implant that on the slit lamp, not even in the operating room, we can basically pick out. I'll show you that once again. You can pick out and take out, because a good portion of it is already out. Now, the problem with those devices is that sometimes, even when you take them out, you develop hypotonies. And you would ask yourself, why would a hypotony occur in a case where you have already removed the implant? But then I would caution and ask you to do a very decent and very thorough gonioscopy, because when you take out those implants, in many cases clefts happen, and with those clefts you can have a very low intraocular pressure that needs, unfortunately, a revision that might end up with a high pressure later on. So in the 7 minutes that I was allowed by Tanuj Dada, my very dear friend and the organizer of the symposium, I tried to give you all what I think I can give in 7 minutes. If you need any more details, here are my contact information, and I thank you very much for your attendance. Thank you.
Thank you, everyone, for allowing me to speak today. This is about preventing problems in transscleral laser micropulse therapy, and I have to show my affiliations. Okay, basically, transscleral micropulse treatment has not very many complications, so really talking about preventing complications isn't such a big deal as making sure that our therapy is successful. I think the main complication is therapy doesn't work very well. So we'd like to remind everyone that this is a transscleral treatment using a probe, and we have to be perpendicular to the surface of the globe, and we have to apply the tip over the pars plana, running a sweeping motion. So do make sure that you keep the right side of the probe towards the limbus, don't reverse it, and position it about 1 to 2 millimeters back from the probe, so fiber optics over the pars plana. Don't go to anterior. People tend to wander anterior, and they tend to treat the pars delicata, which is the wrong place, and treat with controlled sweeps. Don't go too fast, don't press too hard. Don't tilt the probe, because then the laser will spill out and energy doesn't go into the eye. And don't float, so that you don't have no coupling between the eye and the probe. You can see here that if it's uncoupled, the shape of the energy changes from when it becomes coupled and you put it into the other fluid. So we have to make sure it's coupled and wet. Here we are showing you the typical sweep speed. If you want to do 180 degrees, this is the sweep speed you should try to achieve. Don't go too fast. You must try to get maybe about 10 seconds for a sweep, not too fast. Otherwise, you end up having less energy delivered. At the same time, you also don't want to go too slowly, because then heat will build up. If you cannot do 180 degrees because you cannot keep the probe perpendicular all the time, then do quadrants, because that's easier to do. And then after you finish one quadrant, if it's a bit tight, you use a little bit of a help to move the eye up and do the other quadrant. And that way you can keep perpendicular, keep in contact, and so there's good coupling at all times without having to lose efficiency of energy, and therefore all the energy you use gets to the eye rather than is wasted by either being absorbed by the conjunctival blood vessels or spilling. So first thing to remember, technique. The incorrect technique moves the fiber closer to the limbus, resulting in unwanted side effects like pupil dilation, maybe corneal damage, and therefore probe orientation and placement is critical. Keep over the pars plana. Position your probe to ensure that it is perpendicular so that energy is maximally transmitted through the sclera to the pars plana. And if your speculum is in the way, maybe you may want to remove it, especially with very small eyes, with narrow palpebral apertures, or who are very deep set. You may want to use instead a squint hook to help you position the eye. Poor tissue coupling will result in less energy being delivered. So you have to make sure the eye is moist and there's good fluid interface throughout the entire procedure. So in other words, keep adding a bit of coupling medium, liquid or something to just make sure that there's a good fluid interface. And titrate your parameters well. Now, titration is a key to avoiding complications and, of course, getting good results. Why is this? Because if you have to remember, machines are slightly different. There's a variation in actual machine output. Each machine has got a little more power, a little less power than what is actually presented on the power display, because it's got to come out of the machine port and go through the fiber optic. So you may have a little higher or a little lower power, and this may be consistently a problem with each machine. It's not so much a problem, it's more a characteristic of your machine. So you've got to get familiar with the machine and titrate your power to suit your patient outcomes. Also, the fiber optic itself is not exactly identical. You may have had a little bit of rough handling or reuse, and if the fiber optic gets a little bit kinked or damaged, then power through the fiber optic may decrease, and then you won't get the same power again. So bear in mind that that also affects the power at the tip of the probe. If you get too little effect consistently, you may want to increase your power or decrease your sweep speed, and of course the opposite. Now, the other thing to remember that's very important now is fluence, because by increasing the rate of travel of the probe, you also change the amount of energy delivered to the target. So a slower moving probe delivers more energy to the target. However, that also allows heat to build up. So you've got to get the right speed. You should maybe keep the number of speeds at no more than 4 to 5 for a 50 to 60 second 180-degree treatment. Your travel speed should be maybe 10 seconds for the entire 180 degrees or slower. And maybe you should think about that as another way of thinking about that is moving at about 1 millimeter per second across the eye or slightly slower. Remember, too slow and heat may build up and cause heat damage, which you don't really want, while going too fast may mean that you're not getting enough dose to the delivered target, and therefore your IOP will go down as well as you expect it to. So therefore, in conclusion, basically technique, machine, sweep speed, and dosology all affect the outcomes of our micropulse treatment, and by being aware of these, you'll get less treatment failures and better outcomes with less complications. I thank you for your attention. I thank my glaucoma team who is helping me and supporting me in all this work. Thank you for your attention.
Hello, everyone. I'll be presenting difficult situations in trabeculectomy surgery. I have no financial disclosures. So how to deal with post-operative hypotony after trabeculectomy? So this is a situation one may often face after glaucoma surgery. So the first technique I'm going to show you is called transconjunctival suturing. So this is a patient, 40-year-old patient who has had a trabeculectomy with mitomycin C and has presented with a very low intraocular pressure of 3 millimeters of mercury. It's a diffuse elevated bleb and there is no obvious leak. So such cases, you can see on the anterior segment OCT, there is excessive filtration of aqueous occurring, and that is the cause for hypotony. So what we are trying to do is to close the scleral flap without opening the conjunctiva. So this is called a transconjunctival suturing. You start from near the limbus, take the 10-0 monofilament nylon, through the scleral flap and try and close the scleral flap. So you put multiple tight sutures, and with that you are able to achieve a tight closure and reversal of the hypotony. You can see now the large cleft has become closed, and over time the epithelium goes over these sutures and they are no longer visible. They get embedded in the conjunctival tissue. So this is the first technique, transconjunctival suturing for early hypotony post trabeculectomy. If this technique does not work, then the next technique is an open surgery. So this is a patient who has had a hypotony, a long-standing after trabeculectomy. He has had 3 times AC deformation with air and with viscoelastic, but the AC is again shallow and hypotenuse, and the eye appears very quiet. When we examined the eye, there was no obvious leakage, just a large diffuse bleb was visible. But when we did the ultrasound biomicroscopy, you can see there is a shallow AC, the iris touching the periphery of the cornea. And here you can see a large pocket of aqueous. So this large pocket of aqueous told us that there is an excess filtration occurring through the scleral flap, and that is the cause for hypotony. So we decided to do an open repair. So in this case, we had not localized the area of the leakage. So we had to open the conjunctiva. And after the opening the conjunctiva, we applied trypan blue, but still we could not see an area of leakage. So we cut open the episcleral tissue to expose the area of the scleral flap. And now you can see after we have applied trypan blue, this area shows that there is a leakage. The scleral flap is not opposed here. There is a large gap, and this may occur if excess cautery has been done. So this large gap has to be closed. So here what we have tried to do is we have raised a transverse scleral flap from the lateral side. So this is the lamellar scleral flap being raised, and this is reflected on to cover the area of the defect. One advantage of using this flap is that it's a lateral flap and you have the posterior aqueous egress is still there. So the bleb can still function. So you can see now the sclera has been, a lamellar scleral flap has been raised and rotated to cover the area of the defect. So this technique you can use if you find on exploration there is a gap in the sclera. And after that, we have used a biodegradable collagen implant, although this is not necessary. This is just to prevent the postoperative fibrosis and failure of the bleb in the long term. This you can see the postoperative day 1 appearance, and the repair has been done now and the hypotony resolved. And this is the postoperative ASOCT. Now you can see the aqueous lake is not visible. Coming to the third case, this is a patient presenting with a history of blebitis, and there was a thin cystic bleb at the corneal scleral junction at the limbus. So this prevents a surgical challenge. It's a thin bleb, already patient has blebitis, so you have to do surgical repair. And you can see very thin cystic bleb, which has to be repaired. So here we decided to just use the OCT guidance to help us in dissection, and you can see this thin cystic area here. So we decided to excise the entire area of the bleb. So you can see now we are excising the bleb. The problem was the bleb was also over the cornea. So you also have to excise this thin cystic bleb on the cornea. And now you see this gap is there. So this is a full thickness defect, which was just covered by conjunctiva. So now first thing is we have to dissect and have a loose conjunctiva all around. And then what we are going to do is you have to measure this area of the defect. And we are using a punch here, a 3 millimeter diameter scleral graft is taken. And this will snugly fit into the area of the full thickness defect. Now to prevent unnecessary suturing, what we did was we made a lamellar pocket 360-degree and tapered the margins of the graft so that the graft can snugly fit here without need for excessive suturing. So now we are tucking the graft in to the lamellar pocket that we have created. And after the graft was put, the problem was that there was still a defect in the cornea. You can see this large defect in the cornea, and the conjunctiva was not being approximated. So then what we thought was that this area, which has got a step in the cornea, we'll use a biodegradable collagen implant over this sterile graft. And this is all done without suturing. And then we have tried to approximate the conjunctiva, but we realized that the conjunctiva is not adequate. So what we have done is we have taken an inferior conjunctival graft. This is an autograft. And then we will overlay onto the area of the cornea where there is exposure. So now this graft has been put here. So now you have a conjunctival overlay here and the autograft over the area of the cornea so that there is a complete coverage of the cornea. If you don't do this, you can get a Dellon formation. And now you can see the two conjunctivas are being approximated and the inferior conjunctiva is sutured. So with this technique, you can get a complete closure of the cleft and you can see a well-defined conjunctival overlay. So these are some of the techniques to manage hypotony post-trabeculectomy. And you can achieve a good post-operative outcome if you plan these surgeries in advance. And thank you very much for your kind attention.
Hi, this is Rick Sponsel, and I'm privileged to be able to present this important talk at the invitation of Drs. Sherwood and Hafez about glaucoma surgery for the underprivileged. Glaucoma is a big problem, particularly in Africa. Is one of the big three causes of blindness, but in Africa it is the predominant cause of blindness. Throughout the world, as one can see here, the burden of glaucoma just continues to grow. And note that there are a lot of people who have glaucoma with angle closure. These people might be helped by cataract surgery alone. There are a lot of people who have open angle glaucoma, and many of them are bilaterally blind. There's also this sad situation with people all over the world born with the tendency for ophthalmos, and it would be so good if we could find them before they end up like this poor child. It is true that cataract surgery is something that you can do and leave. Glaucoma surgery is a little more tricky. It requires sustainable eye care. You need hospitals, you need good equipment, you need surgeons and staff. You actually have to find the people. They're often asymptomatic to some extent, even though some of them are nearly blind. And you have to make the whole thing sustainable. So it's taken a long time for us to realize these important facts, and you can go with good intentions and sometimes not do the right. It's wonderful to work with such a great group because many of our ISGS members and fellows are involved in international outreach, including many members of our Society's executive committee, including our current president, Tariq Sharawi, and founding president, Andre Mermoud, who I'll choose as two examples of people doing wonderful things. Tariq, you see here operating, has done stunning work in Upper Egypt and has coordinated, along with others, at least 17 different centers of excellence to help serve not only the urban population, but the rural population throughout that large country. And they have their own eye center, as well as interacting with people all over that nation. And clearly they do a considerable amount of glaucoma surgery and have much to say about how to handle it in their setting. Vision for All was founded by Andre Mermoud. He began even as a resident ophthalmologist visiting India from Switzerland and opened a hospital there. It's still functioning and has done stunning things throughout the world. I'm so proud to know him and be his friend. But here you see the largest African hospital for eyes in Rwanda that was just constructed with a substantial contribution made by Andre and his foundation. And he goes, as you see here to the left, he's screening someone even in a restaurant in the beach. And the next thing you know, he has this fellow in, and they're operating as a team. Obviously, it's very sustainable. And as you can see, there are many local surgeons involved, which is part of the secret to success, particularly for glaucoma. But I want to warn you, I mean, there's some general principles I really want to get across, and that is that in the absence of well-equipped local facilities with skilled follow-up, it may be more prudent for visiting surgeons to perform lasers and cataract surgery. These things don't typically have too many post-op complications. And it's good to know there are many cases of chronic angle closure amenable to YAG iridotomy or argon iridoplasty, so you can get a device, portable device to somewhere in the middle of nowhere, you can do amazing good. There are also many intumescent or opaque lenses inducing chronic angle closure, so just taking out lenses and replacing them with IOLs will do a lot of good for the glaucoma as well. And then SLT is remarkably effective in people of color, and I want to cover that really quickly. Here we see that Tony Riolini and his group have done an amazing job finding that people of color in the Caribbean get spectacular responses, are almost as good as surgery. So why would you operate on them if you can do something with a simple laser that's so low in risk? And we carried out similar studies in Africa and found indeed that he was right. And as a result, the African Glaucoma Consortium was born in Helsinki as a result largely of these two studies, I guess. And as you can see, it's interesting, on the left, the black patients in particular respond well. The Indian patients in Durban, which is the largest Indian city outside of India, would make up almost a third of the population in the study, also get good responses, but they're noticeably and statistically significantly less spectacular than the black patients. So black patients really do respond extremely well to SLT. The other general principle I'd say is avoid expensive implants with negligible or low long-term IOP reducing efficacy. Avoid traditional implants unless skilled long-term backup is available and scleral graft is available. For patients at high risk of visual loss, embrace incisional procedures with high IOP reducing efficacy and lower probability of postoperative complications, and where necessary, be willing to substitute diode cyclophotocoagulation for surgery. Deep sclerectomy, I'm sure many of you are familiar with. Here's an illustration from a paper by Drs. Barton and Shrawi and Sorodia. And this technique has demonstrated efficacy in Rwanda, Ivory Coast, and Togo by Andre. They published some stuff in the French Journal this past year. And here you see the procedure, the technique. You're all familiar with it. This is a comparative study we did. It looks like it's a lot more safe to do this than it is to do a trabeculectomy. And the complications are minimal with a deep sclerectomy, and IOP reduction and medication reduction is good. And here you even see increases in visual function in the long term. So it's a great operation. Andre does it with an inherent iridectomy thrown in. Now, final points. We really believe sustainability is the answer. So we've created clinics which will invite any of you who would like to come to work with us in facilities like those that have been in Egypt and also throughout Africa by Andre and India. And we want you to come. And I'd finally like to point out that we've done some fantastic genetic work that's been published in JAMA recently as a result of our intervention. This may help us understand the underlying basis for glaucoma. If any of you would like to help us out, please come work with us anytime, get in touch. And please, if you would like to, go ahead and join in the climb we're going to do this end of this month. Or at least donate so that we can double the size of our clinic in Africa. Thank you very much.